So I'm going to be talking about generic drug pricing in Canada, which is an area that our team at Chesper's been doing some work on over the last couple of years. And I just want to start with a couple of things that I think are important to recognize about generics. Generics could be better used in Canada. So right now we fill about 60% of our prescriptions with a generic alternative, whereas in the United States about 80% of prescriptions are filled with generics. We could do better on that front because generics will always save you money, especially with the way we price. Our generics always come in cheaper than the brand. The other place that I think we could do better in Canada in terms of generic drugs is on the prices that we pay. And this is a consequence of a system that we've created for pricing generics that I think has some pretty fundamental flaws to it, and that's what I'm going to talk about today. So it is just after lunch, as Barbara indicated, so I'd like to sell you all a coffee. And this Tim Hortons coffee is going to cost you $60. I'm pretty sure that none of you would buy that, but it provides an interesting segue into talking about the price of the price that we pay for some generic ingredients in Canada right now. So that's in reference to simvastatin. So for a 20 milligram tablet of simvastatin, currently in Ontario, which has the lowest generic prices in Canada right now, we pay 62.5 cents for a tablet of 20 milligrams of simvastatin. Sorry. In the United States, under the Department of Veterans Affairs plan, they pay 6.9, and in New Zealand they pay 2.4 for the same strength of the same drug. These are actually prices that I collected in a study that we published last year. And since we did the study, the prices in both countries have actually dropped to 3.1 and 1.9 cents. So in essence, the $60 coffee. So how do we price generic drugs in Canada? How did this system come about? What we've done in the past since the 90s is we've priced things as a percentage of their brand equivalent. So in this example here, pre-2006, we tended to price it about 60 or 70% of the brand name. So if the brand cost $1, as it does in my slide, we paid 60 to 70 cents for the generic. In 2006, Ontario really started what became a trend in the country of lowering the percentage. So we went to 50%. Then Ontario again in 2010, in what became a very controversial policy change, went to 25%. This, if you remember correctly, had pharmacists on the steps of Queen's Park, was the subject of about a month-long, very public debate. And next year, BC has actually indicated that they're going to move to 20% of the brand name price. The important thing that I want you to take away from this slide is not so much the movement and not so much what the percentages are, but I'm going to tell you that all of these are wrong. Every single one of them is wrong. So in terms of where that ends us up, these are the Ontario prices versus the price that they pay in the United States, in New Zealand. So I posted on Twitter the link to the paper that has these numbers in them. And there's also a commentary that we had published in the CMAJ last year that does some of these comparisons. The important part of this slide is not just the scale of the difference, but the scale is large. The important point is also the variability in how much the prices differ. The percentages are getting us somewhere close to what we see in other markets in some cases, and it gets us way over the prices in other places, in other instances. The percentages aren't very good at getting us close to what we might think is the marginal cost of production, which is actually where we want to be close to. This slide shows you the top 100, just making the point that I didn't just select a few in the last slide that sort of make my point more strongly. So this is the top 100 drugs in Ontario by volume. On the left-hand side is the number that are less expensive in Canada and the degree to which they're less expensive, so 1 to 2 times, 2 to 3 times, and et cetera. And on the right in blue is the amount more expensive those top 100 drugs are in Canada versus other countries, so 1 to 2, 2 to 4, up to the 7 drugs that are greater than 15 times more expensive in Canada than you find in other jurisdictions. So all of this leads me to the first conclusion here. And the first conclusion that I'm going to suggest is that Canadians pay too much for generic drugs. How much too much? So if you look over those 82 drugs that I was talking about in Ontario, and you apply the price that you see in other comparable jurisdictions, Ontario paid about $245 million more than they would have at internationally observed prices in 2009. So across the country, if you do some back-of-the-envelope calculations, the actual number is probably about $1 billion we're spending more because of our pricing. This hasn't gone unnoticed, and as some people have alluded to earlier, last year the premiers agreed and the provinces worked together to a new scheme for pricing. So this actually sort of in the Council of the Federation's original report on healthcare, this was one of the signature initiatives that you can see here was the subtitle in the Globe and Mail article reporting on the announcement, the plan to purchase generic drugs in bulk. The plan that was ultimately agreed to after about 8 months of stakeholder consultation and development through the provinces was to price 6 drugs at 18% of the brand name price. So moving back to that original slide, we'll have to put another arrow on there. So where did that get us? Atorvastatin is the most widely used drug in Canada if you count up the number of tablets that people take. And this is what it looks like when you compare the price at 18% for 10 milligrams of atorvastatin to what's paid in the US right now and what's paid on the New Zealand formulary. Pretty dramatic differences. And if we got the US price for atorvastatin, keeping in mind that we buy about 200 million tablets of atorvastatin at 10 milligrams in this country every year, there's an additional $50 million for this one drug at one dose still on the table in my view. So even after the changes, I think that Canadians still pay too much for generic drugs. So what's the answer? Where would I suggest we go? I suggest we've got to get these companies competing against one another. We've got to get the competition actually driving us to lower prices. Get the firms to bid, get them to respond to tenders to supply our public programs. Because this way you can get the manufacturers going against one another and really drive things down to where you want to see them. Generic drugs are a commodity, and in commodities, when you're pricing commodities, competition works really well. So with any major change, you're going to want to think about the side effects. So what could this do? What possible bad things might come of this? And what would we want to do or think about when we're making these kinds of changes? So I'm going to talk about 4. The first is the aspect of litigation. I'm not going to go into great depth on this, but I'm happy to talk about it in the discussion. This is the idea that through higher prices, we get generic firms to challenge shaky patents on brand drugs and get us generic drugs earlier than we would otherwise. This is important. We have a system whereby generics can't come to market unless the patents have been invalidated on the brand. So this matters. But there's better ways that we could do it. We could do what the US does and introduce a period whereby the generic firm that successfully challenges litigation has 6 months on the market without anybody else to compete with. This is a short-term reward that would be a big deal for that company, and it gets us out of paying perpetually high prices to try and support these things in a way that's actually not that direct. The second is the potential for drug shortages. So this came up a lot in the public debate about tendering, that tendering generics would lead to the greater shortages. I think this ignores what you can actually do with a tendering contract. So what you can do with a tendering contract is you can go out and put stipulations on that supply. So you can say to manufacturers, you need to stock this many months of back supply. You need to pay if we need to go and source this drug somewhere else. And I think it's kind of ironic that if you look globally at countries that have used supply contracts, that a number of other countries that would be comparable to Canada have used these contracts as a way to ensure the security of the supply, not as a way to draw it into doubt. The next 2 that have been raised I'll deal with in a couple of slides. The first is the idea that this will impact generic manufacturers in Canada, and the second is the idea that it'll have an impact on community pharmacy, both of which are important to think about. So in terms of the manufacturers, we need to recognize that this is an incredibly global market. Canada is a small part of it. Even our manufacturers in Canada supply in a bunch of other places. And the numbers kind of tell the story in and of themselves. Our Canadian companies sell in other countries far more cheaply than they do here. It's also important in the terms of community pharmacy. So let's follow the money. The money for a generic drug goes from government to the pharmacy. The pharmacy then pays the manufacturer that ingredient cost. But what happens then is off the invoice for that bill, a rebate is paid back to the pharmacy. So pharmacy stands to lose here if those rebates decrease in size. And the claim from pharmacies is that the reduction in those rebates is going to impact their ability to serve patients. It's going to result in store closures and whatnot. And that was really the thrust of that debate in Ontario in 2010. So our group did some examination of this. And we looked at community pharmacies in Ontario. So we actually mapped out every community pharmacy in Ontario. And we looked at people's access to pharmacies and did some simulations about whether or not if pharmacies closed, would this have an impact on people's ability to access a pharmacy close to their house. And I can refer people to the paper if they're interested, but one of the key things is that we found that 44% of people in Ontario live within 800 meters of 2 or more community pharmacies. So they have walking distance access to 2 or more pharmacies. I personally have walking distance access to 8 pharmacies. I also live in an incredibly pedestrian area of Vancouver, but this is a level of pharmacy access that I think is quite high. We have 40% more pharmacies per capita in the United States, so I don't think we have much to worry about here in terms of access to pharmacies. And I'll also point out that the proof is in the pudding. What happened in Ontario after they cut the prices from 50% of the brand name to 25% of the brand name? Well, 52 pharmacies closed in that first year, which would be a concern and would be a problem if 159 hadn't opened. So the increase in pharmacies was 3%, whereas the increase in the population over the same period was 1%. In the year after that, because you might think, well, this would take a long time to have effect, in the year after that, the net gain was 30 more pharmacies, and that's after you account for the 95 pharmacies that Target temporarily closed when they bought them from Zeller so that they can renovate them and reopen them again. I don't think we need to be concerned here. So the system's broken. The way that we price is broken. It doesn't work. We're paying more than we should in a context of scarce resources, and millions of Canadians are unable to afford their prescription drugs right now, as we heard in the earlier presentations. There's serious cracks in the road, and changing percentages is like putting duct tape on them. We need to stop fiddling with the arbitrary percentages, get on with leveraging competition, and get Canadians access to the generic drugs they need at a competitive price. I want to point out that I also don't put blame on generic manufacturers or pharmacies for engaging in this type of pricing scheme. We set the rules in this country from a public policy standpoint. We set these thresholds, and we say you should price below this. So the fact that they do that should come as no surprise. It's not their fault, it's ours. It's a system that we created, and it's a system that we need to change. Thank you very much.